Good evening. August meeting to order. 5:15 on Tuesday, the 17th. We have roll call, please? Or are you distracted?
I'm just, I'm describing, but we want to go around and say who's here, but I'm noting who's.
Max. Helga here.
Jeannie.
Yeah, and we just had Berkey walk in the door, Dr. Hernandez, and we have Chris Waterman online. Great. Now, I would now entertain a motion to approve the agenda as it's presented.
Move to approve.
Thank you. Do we have anyone? I don't see anyone in the room, but do we have anyone online who is here for public participation? Okay. Seeing none, I would entertain a motion to approve the minutes of the January 9th Finance Committee meeting and the January 22nd Audit Review, Finance and Audit Committee meeting. So the 9th and the January 22nd committee meetings. So moved.
Sorry, I didn't catch who approved them.
I'm, motion
Okay.
to approve. And Brett, are you second? Yeah.
Brent, thank you.
All right, we've got through the housekeeping stuff. I'm going to, as soon as Max,
I'm ready.
we'll just chat first. I'm
Good.
going to turn it over to Max for the
Thank you.
balance of the program.
Thank you, Deb. So item 6 is the FY27 budget presentation, and Angela has prepared the budget as required for the CDJ's format. And I'll turn it over to Angela.
Thank you, ma'am. Let's, sure. I'll give you a bit of a history on how the budget was constructed, so you have the background, and then we can discuss the numbers in greater detail as you require. The fiscal year 27 budget methodology is based on historical performance and individual interviews with the department directors to obtain their key knowledge of operational changes. The historical performance is December 2024 through November 2025, because that was the 12 rolling months, and November 25 is the last period finished at the point the budgets were created. The revenue was created by only increasing commercial insurance by 4%. When we take that 4% increase on commercial insurance and we spread that across our entire payer mix, that is where it blends out to 1.4%. So what we'll see in any of the subsequent documents is a 1.4% on total revenue, but it really is only 4% commercial insurance. We're not increasing the other types of payers. There were some new service lines that were added. Those were calculated out differently. That was Bartlett Family Medicine with an annual revenue of 4.1 million. That is based off their 2024 financials. Bartlett Glacier Feeds, we don't have historical information on, so we did an estimate of 880,000 in annual revenue. We just signed with Pulmonology, and so we have the pro forma created that was $1 million in revenue. And then we recently made changes to our pharmacy charge master, and that was 3.9 million in increased charges. And that accounts for the full revenue changes that are from the current trend to the fiscal year 27 budget. Expenses were calculated for salaries, wages, and benefits. We have a pre-negotiated increase of 5.5% for all employees. It is already guaranteed, so that was baked in. And all other expenses, I took an average increase over the past 12 years. It's 3% when you average it out. And that has been applied on all other expenses. Any other changes were based on either aforementioned performance or by doing direct one-on-one meeting with the different department directors. So an example of a one-off change that was made was we're going through the ED renovation. So we know we had to bake in some additional FTE because we have to relocate our emergency department entrance. We have to have people walk folks through the diagnostic. So we know that we have to have people to do for the next 2 years. Okay. Our approach was to prioritize realism. So this is not an optimistic budget. This is an achievable budget. It's reasonable. And it was done with a bottom up and a top down approach. So it was, the formats were all created for the department directors. All of those changes that we talked about with the 1.4% on revenue, 5.5% on salaries, wages, and benefits, 3% on other costs was created for them as part of the starting point for their meeting, and then had the meeting with them and went through any operational changes they were aware of. And then those were baked in and documented, and the entire thing rolled up for comprehensive review. We do know that with expenses increasing an average 3%, wages and benefits increasing 5.5%, and revenues only increasing 1.4%, clearly expenses are outweighing revenue increases. If you exclude any kind of growth, strategic growth that we have invested in recent months and past years. So that is really what's driving the revenue higher and allowing us to achieve a 3% margin in budget. And due to the revenue compression, we will be considering critical access and alternative payment models that Alaska Department of Health has proposed to us. So we can also discuss those further. Those models are not baked in. Any questions on budget?
Questions?
So on the new services that we have, and just, and I'm sure you've done this, but I want to make sure that they're covering everything. Or are they gross over?
I did gross and then I applied our standard contractual of 45.6%.
Okay, thank you.
Mhm.
I just wondered if there was a different contractual applied than what our standards.
I applied the standard in absence of knowledge.
Rural health demonstration. It's not in the numbers we just talked about.
It is not.
So, so it's not in either the annualized numbers or anywhere in the budget for 27 pending it get approved. And could you speak a little bit to the growth in the physician revenue in line 8, just so you know that's a pretty significant growth, and talk about the growth there, and then also the fact that we're not seeing corresponding increases in either the contract or the physician salaries costs.
So I took what had already been baked in, and then I did add in Bartlett Family Medicine and Glacier Peace of Pulmonology. So that is 4.1, roughly 1 and 1, so 6.1 million alone, plus the 1.4%. And then the performance also included salaries, wages, and benefits baked into that.
Okay. Are there other questions? I'd like to talk a little bit about critical access. So, by just way of background, we looked hard at critical access about 2 years ago, or so.
Year and a half.
Year. And Joe engaged the services of,
We use DZA.
DZA and looked at the value of converting to critical access. And we put that on hold at the request of the state because of possibility of getting the SOLS Act, which would convert us to effectively outpatient cost-based reimbursement and rural demonstration, right? So now here we are, a year and a half later, we not only do not have the SOLS Act, but we also don't have the rural demonstration program either. So we're on a fee-for-service basis, and it's significant impact to us. The annual impact of the loss of rural demonstration is about $5 million.
4.2.
$4.2 million. And so I discussed with Angela and Joe is the idea of going back through that and doing some homework. So could you just talk to that? Yeah.
Yeah, so when we first looked at this roughly 2 years ago before we took it to the board, we did have to do a comprehensive review of all the patient stays and look at the caps. So with critical access, you have to keep your acute number of patients under 25. That's a total patients in bed, that's just acute patients. So you can still have observation up to the total 45 beds taken. The difficulty becomes is when you designate a bed as observation, it's only observation. It can't go back to the patient. So you have to go through and basically pick which beds are observation in every single unit of the hospital. We also, I mean, there are multiple steps to the process. We have to go and put a request with the states. We need DOH's blessing on this to start the process, and that's where we got stopped last time. We are looking at payment reform with them, and so there could be some possibility that maybe we move forward with that in conjunction with payment reform. So when we were looking at the head model, which the state is pushing towards or wants to, if you're a critical access hospital, basically there's a hold harmless provision. And so if your payments end up being less than the cost-based reimbursement, Medicare makes you trigger this demonstration. So under critical access, you're basically held harmless if your payments go below that. So there is an in-depth enough. We had a higher census over the last 12 months than we did during the initial review period. So I believe that in-depth analysis would be needed to get before we just have to make this jump. Yeah, last summer was particularly busy, so we need to know how many days we exceeded these patients, what those payments were, and why they were in our hospitals. We kind of come up with some plans and how we handle those patients.
So your thought is to proceed with that, right?
Yeah, we can start that analysis, and it will take a while to get that done. It's not our EMR doesn't facilitate an easy analysis. Basically, you have to pull patients by day, figure out which days you exceeded and look at every single one of those patients. What you're looking for is which ones are actually being held due to no beds for long-term care or skilled nursing. We can remediate that problem in some other way.
Good. Comments, questions about that?
You mentioned something else,
SOLS Act.
Souls Act, what is that? That's something.
So that was, SOLS Act was, the idea was to essentially provide cost-based reimbursement for those small facilities that are not critical access for outpatient services. So, you know,
Right,
the idea
okay,
of-
yeah, and that's a federal legislation.
Yeah.
That was proposed, but that's.
And it's gone now, what, 3 times, 4 times, they've tried to get it passed and they haven't been able to get it across the finish line. So I think it's reasonable to assume that probably won't ever get there.
It's one of those things that got tucked into the one big beautiful bill that actually didn't meet the reconciliation rules. So I had to strip back down. So Diane Murkowski did her best to do trade that.
Yeah. Kowski and Goldman both look like that. And so this seems like, and I think, you moving forward with this doesn't require board approval, but I think it's important for the board to be informed about that and that everybody kind of understands that, there's a reason to go forward with it. And part of that analysis will be not only the impact to, the bed utilization, but also what the net revenue impact will be, right?
The biggest piece of the net revenue impact cost-based reimbursement.
And how much roughly was that last time you looked at it?
It was an additional 8.2 for outpatient, so you're looking at $12.4 million net revenue.
So I mean,
So significant.
it's significant, yeah. And, you know, will it also look at the impact of these other strategic things that we're doing, such as the clinics, you know, the revenue expansion, some of those it'll sweep in, you know, kind of look at all those.
Yeah, we'll have to do some analysis and try to use the budget as for allocation of costs out to those clinics. There are also statuses that we can give to the clinics as critical access. Rural clinic becomes an easy one, as well as it changes some of the 340B dynamics that we experienced today. I think that was more of a negative than a positive because it pulls certain drugs out.
Yeah. And how long will that take?
The patients is gonna be the longest piece. Doing the cost-based piece is easier, I think. So we can get the dollar amount to move to cost, but how the patients are impacted takes a little bit longer. I would guess no more than 2 months. So I see a three-pronged approach here. So we need to continue to work with the state on what current models they're looking at with payment reform. We can look at critical access while we continue to push the feds and hopes for demonstration. Then extending demonstration and return it back will be the quickest way forward. Critical access does take a while.
Yeah, but at the same time, that also would only be the rural demonstrations is inpatients. And which is, you know, a third of our revenue. Right?
Yeah.
The biggest piece is outpatient. That's why critical access really has the value. Right?
Agreed.
So you'll report back to us.
Yeah, we'll try to get it back to you in April sometime.
Thank you. Lisa?
Certain revenue on Wildfire Court, is that still, I remember when we first purchased, got and acquired Wildfire Court, that any profit from that had to remain with Wildfire Court. Is that still true? The hospital benefit.
It all rolls into our books at this point. So 80% is based on cost-based anyway, so you're not making money on Medicaid. And so it does show a margin in the financials when you look at them, but we'd have done full allocations. So there's not a huge amount of profits that we're worried about. Back.
Thank you for that.
Yeah.
I just wasn't sure.
Ansel?
Yes, sir.
Is there more?
There is the CIP list.
The pages that follow this, she's gonna be scanning through, these are really just in the CBJ's presentation form, right? No new numbers, nothing different, we're just regrouping them for CBJ.
This list of CIP is based on the meetings and the submissions by the various department directors. It lists the order of importance to those directors, as well as estimated timeframe of execution and estimated dollars and department. And if you scroll down to the bottom, is about 9.3 million. 3.5 of that is a reserve for potential housing expansion at Heartland House. About 5.8 million in various equipment and material replacements.
What is the Aurora infusion and pharmacy renovation? That's the other big one, down to 1.5 million. Is that something we talked about as part of the master plan? Yes. So that's a piece that
It's moving.
that you want to move, right, that you want to move forward with.
It is a placeholder.
It's a placeholder.
Yeah.
It's based
For that. That's fine.
And that really nothing else can happen until in the master plan comes back.
Some of these figures for left justified and some are right justified. Is there some significance to that? Is that telling us something?
It is not, it was when we put it into the CBJ. I'll own that one.
Kind of along the same lines, though, there's a lot of these are round numbers.
Yeah.
And how did you guys do cost estimation? You know, the 1.5 million is a great example.
So we had the facilities director, Mark, who's been with us for, gosh, almost 30 years, I think. He had a square foot price and then he walked the space. We discussed what needed to be done and he came up with the estimate.
And the others, all this capital, you know, the equipment related items, how are those estimated?
The different department directors took historical costs for similar replacements and then added a factor on top of that for increased cost.
Let's say in a normal budget year, we request quotes, but when then we shorten the time frame, it just became impossible.
Yeah, right. So we just have to get a, I guess, you know, I'm channeling Kenny Solomon here a little bit. That we have to be aware of the fact that when these come back to us, they could come back at a different number. If we get a little bit more time on how this we thought, right? And the priority, the critical, urgent, routine priorities that you have on there. I'm just reminded when I see that in the last 6 months or so, we had 2 or 3 times where, you know, you guys brought, there was a communication thing and there was a bed thing at one point. And do we feel like, I mean, you know, you don't know about an emergency that you don't know about, but do you feel like this is a fairly comprehensive list of what could be out there over the next year?
I think we stress the importance of going through their whole department and grabbing everything. That's why the list is probably quite a bit bigger than it has been in past years. But there are certain things, I mean, our goal over the next 12 months will be to get everything loaded into a system with a useful life. So we can just track that side. That's just, it's still a project process.
I noticed that there are 2 items on there that don't have a priority. The delivery robot, and the cleaning robot.
Those are actually mine, that is, those are items that we are looking at, we would be grouping in with the potential effect or in EHR upgrade. And they would be value add to offset some FTE hours. But I did not assign a priority because we're unsure where that's going to stand.
So this would be a request of rural health transformation. That's where we go after. But we do have to have it in the capital budget. Yeah.
So how does this list, since I'm new to the budget process, this list roll into the budget? Is there a line item where I can find this 9.3 million in the budget, or is this the capital outside of the?
This is the
Budget.
capital.
Okay, so it's outside of.
Yes, the budget you're looking at is the P&L.
Okay,
And CBJ requires us to submit this
okay,
as a separate item.
as a separate item.
Well, you bring up a really great point. Yeah, how does that tie back to page 12, the support the capital projects? We have some 4 million for FY 27. How does the 4 million compare to the 8 million or so on the CIP?
So your capital outlay is 9.3.
Yeah,
Capital projects we moved in is 4 million because we only want them to take the 4 million and put it in reserve.
The difference is capital, we control capital, CBJ controls. And so the CIP, the capital projects is deferred maintenance projects. Like we have very specific stuff we use that fund. It's to handle through CBJ and engineering.
gotcha.
So ideally, the stuff we can handle ourselves, we like to.
So the things you handle yourself under capital projects, things you can't or capital.
Where do we stand on the repayment of the debt? The $2 million over, you know, because we did the 1 year and then settles and
Well, the CBJ, I'll answer this. I kind of made the decision. When they reached out and asked if we were going to allocate additional years worth of payback, I elected to push it a year because we decided to do this over 3 years.
yeah,
And we did one in 26,
yeah.
and then we also funded
Sobering.
Sobering Center, which I see as year 2. And so I want to make sure
That's in this budget then, FY 27?
it's gonna be in 26.
Yeah.
And
It's
so
already
that,
been funded, hasn't it?
it's already been funded, so we'll have to do an appropriations change.
So we've got 2 years of the repayment.
Already done.
So is the third year then here?
Nope, that's gonna be in the 28 budget.
I see.
So with just all the uncertainty around our payment methodologies with Medicare, I wanted to give us an extra year. I feel like we've already paid those two, so.
That's fair. And the CBJ knows that? This month?
Maybe we should, yes. And that's, I mean, I kind of made that decision as CEO. It is up to the board's discretion to change that if you guys like to.
Whether it's 26 or 27, you mean, or what?
Well, yeah, if you,
Or the third?
I think at 27, so we had 2 years, 26, so I figured 28 was the scheduled third year. So that's where I left it.
Okay. Also okay with that? With that?
Works for me. Postpone it for a year if possible. That's good.
Yeah.
That's the cycle that we run anyways.
So let's talk about the 3.5 million for the housing expansion Bartlett House. So that number is a estimate at this point?
Yeah, it's a sweat, I guess.
You consider including that in a rural transformation request?
Yeah, we'll still put a request in for that.
Right, but that's.
It still needs to be
Yeah.
budgeted.
I was smart that.
There'll be several of these we'll try to go after.
Okay, that's.
But I think it's, let's just, I just want to make sure the whole board is familiar with the fact that the Bartlett House is owned by Bartlett, which is owned by CBJ. So earlier, when we were working with Bartlett Foundation, we were thinking they would be the constructor of these things and we would bring money. That's changed now, and we will be doing it through the normal CIP project for process with CBJ, right? And that process, we'll have to take that through planning and just go through all the normal steps that we have to go through, correct?
Yes.
And do we have a timeline set up for that yet?
We haven't even really kicked off that piece of it. And so,
Yeah. That's fair. And so there's a lot of work that $3.5 million means, but what we're doing is just getting ourselves the authorization for that. When we meet with the assembly next week, I'd like to get that encapsulated into part of our discussion. Deb, it's just the idea that we want to build these units. We think that it would be a great addition. We've been working on this. And that's what this number is. It's our contribution to try to make the housing situation in June a little better, you know. Talk about that. Okay. Any questions
Yeah, I
about?
think our recruitment
Yeah.
and retention.
Question. Any other comments or points or anything about the budget?
Yes.
Does anybody want to make a motion at this point, or is it more questions or discussion?
Being done. Do we have a motion? There is the motion's up there.
So I move that the board of directors approve the FY 27 budget as presented for transmittal to the CBJs.
Any,
Second. Any objection to that? Okay, hearing none. Well, thank you, Angela. Just one comment about that. I've asked Angela to prepare the monthly budget for us, to take this and divide it out. You know, she's already got it, but, you know, and I'll go through whether we might bring that back to a future finance committee meeting just to go through it too, so that we can all be familiar with how the year should develop next year.
straight, you guys discuss whether it be straight line or seasonal. Yeah,
She'll parse it out.
thank you.
Next item, December financial results. Back on you, Angela.
So the paper story does look negative, and I'm gonna tell you why it isn't. Just call it what it is. Get it right out there. There are a couple of key factors going on here. One is we are improving accuracy.
Excuse me, Angela, could you just, let's just get people centered on what the numbers are showing and then let's put it into context if you wouldn't mind.
Absolutely, thank you. So the month to date shows a negative 240,000. No, stay where you were. Thank you. And the year to date shows a negative 1.2 million. And here's why that isn't a bad thing. Stick with me, I promise. Okay, we are doing something I talked before about. We are standardizing the way we apply our contractual discount to the 45.6%. We know it's 45.6% because we just went through audit and they validated that. So that is what, on every dollar that we charge, we are not collecting 45.6%. We are collecting 53.4%. So that's what that 45.6% means. If you look at the historical financials and if you look at budget, the contractual rate is not flat. It fluctuates every month. So for example, in prior year, December 24, the contractual rate was 44.6%. Okay, it's not far off, but that's about $657,000 difference in what drops down to the bottom line. If you look at the budget for December 25, the contractual rate is 37.4%. That's a $3 million difference. So instead of seeing contractuals do this, we're flatlining them. We're getting a better accuracy. We know what we're going to collect, and that's what we want to represent every month. Looking at historical financials, you see them do this, and then the contractual rate went way up at the end of the year because we're playing catch up. That's not going to happen this year. So this is a time issue. So instead of having low rates now and big pickups later, you have consistency. So this is a good thing, but it looks painful at first. Second thing is depreciation. So we know in audit, we found the $12 million of assets that needed to be capitalized that were not capitalized. And in audit, we saw that big adjustment through June of 25 that popped that up. Well, we then had to move that into the current year. That is a $1.2 million pickup. What are we losing here? Year to date, we're down 1.2 million. So in essence, if you set aside the contractual discount flattening out, we're flat without that depreciation catch up. Depreciation is non-operational, it's non-cash. It's money that was spent years ago. It relates to assets from fiscal year 22 to fiscal year 25. So this is just a catch up and a cleanup and fiscal discipline. So it doesn't look great, but it doesn't reflect on operations. That be for us. Yeah. If we look at the revenue headwinds, we have rural health demo, which was 4.2 million. And if you take that 6 months, it's 2.1 million of revenue that's we're not receiving that we would have anticipated. We had the one-time wildflower port interim piece for 3.5 months, where our fees were reduced while Department of Health worked through what our reimbursement rate was going to be for 82% of our census over there. And it was a $1.2 million one-time hit. We had startup loss from Bartlett Family Medicine of $730,000. And we had initial startup loss from Bartlett Glacier Peaks of $99,000. All of that together is $4 million. 1.9 of it is one-time events. From startup losses to wildflower or interim reduction for 3.5 months. So almost 2 million of that. So if we had the 2 million back from the one-time events, we're actually doing pretty well. What all that means is there's not a structural issue. There isn't a downturn in operations. There isn't a concerning mitigating issue. This is strategic investment and one-time events. And then, of course, we know what happened with demonstration. So if we take that minus 1.2 year to date, we add back the depreciation, which we just found out about this year, which was a cleanup consistency issue. That would make us flat. Strategic investment and one-time, one-offs, it would have been a positive to low. So it tells us structurally and strategic. Next, did you have a question?
Does anybody have a question? About that? It's a lot to.
It's a lot to chew on.
Yeah.
And the numbers look really scary, but we are still doing the right strategic things. We are still operationally sound. There is still a brighter horizon. It is explainable.
One thing I do want to just, an observation and focus areas, is row 36 is our income from operations. So the net income or the net loss includes row 37, which is this investment income that we've booked year to date, which is our allocation of all the meetings and everything we have from our investments, which we can't count on that. And really what we should be focused on is our income or loss from operations. So when you're adding back, you're really adding back to the $2.3 million loss that I'm seeing, but you're still, you know, if you add back your 1.2 million, your $2 million one-offs, it still gets you back. And then your contractual, which you didn't talk about, which is, so those all put you back kind of above the line. So what's January?
Better. We saw a recovery in census, and, you know, the January budget, the contractual was actually higher to 5.6%. So that's going to be favorable. And we did have to shut down some services in January because of Snowmageddon. But it was a stronger month than so.
We know hospital only revenue, just because Benetech has access to that, we were up 1.5 million gross revenue in hospital operations during the month.
In January.
Yes. And that is with us shutting down for a few days. What doesn't include is we have to pay a deductible and insurance claim.
Yes.
For
For the city, it's $500,000. We have not been given our portion.
I imagine we'll get a chunk of it.
So, you know, so this contractual, I think I know the answer to this, but this goes up and down because of the payer mix, doesn't it? And that's all it is. But if healthy people get, I mean, if people, well-insured people get sick, then get something else. If it's on Medicaid, it's something else.
And that's seasonality affects that because of the cruise ship, you know, bumping some.
But if we flatten it out, we get a more realistic picture throughout the year.
Okay, moving on. Any other? Could you go to the next page, maybe speak a little bit to wildfire court too?
Wildfire court, we got the pipe break, it's the end.
Yeah, it was the first day of call with the first, is it January 1st?
January 1st.
31st? 31st?
So not a big impact there. We will see an impact in January from COVID census. But wildfire report, this does not include their contractuals or cost allocations. So those will start segmenting out for the different service lines as we restate the financial, well, restate the financial package, and then beginning in January start adding in cost allocations and making sure each service line has the contractions. So you'll have a realistic picture of each service.
Great. That was my question. So we'll get the January reports will show a year-to-date cost allocation and monthly and we'll start having that every month.
Yes.
Going forward. Same with hospice and home care, assuming here.
Yes, and all service lines will be reduced so that you could add them all up and get to the consolidated. So it becomes a complete picture.
Great. Any questions on wildflower? I've got another question when we get back to the charts on wildflower. Balance sheet, do you want to go through anything on balance sheet?
I would like to discuss it.
Yeah.
So looking at the balance sheet,
24.
here we go. When we combine cash, which is those first two lines, you'll see that there was a big decrease. It is $12 million. That 12 million, 7 of it moved into restricted capital. So really, the cash decline is 5.6 million. 1.4 of that was bond payments. 1.1 of it was settlement for the cost report. 1.8 was an additional payroll we paid in December, and that was to facilitate the transition to UKG. So that was pulling the payroll in. We used to have a 2-week lag. We now have a 1. So it was that additional payroll coming in December. And then there was 1.3 million where accounts payable was paid down. So it was all timing and planned financial stewardship. There was nothing significant. It will rebound.
So why the shift to line 9 then? Why did that occur? I hear that it was for 7 million, but why did that happen?
We had to submit that original breakdown to CBJ on land at CIP, even though we didn't have the detail outlined yet. And it's the 4 million plus a couple other large items. It does not include the housing piece yet. Whenever we tell them anything about CIP, they put it under restricted. The cash doesn't physically.
Yeah,
Just which bucket it's in.
even though it's not appropriated yet, we think
Yes.
they wouldn't do it until the beginning of FY, right?
It comes through their fund. They rebuild it.
Okay, questions on the balance sheet? Okay, next, Angela.
You got a question on? Sure.
I'm not quite there yet. If we could stop at page 26 and 27 for hospice and home care. I guess the first question I had about this is how are we doing on bringing things in-house?
The team is actively working on it. They have gone through their training. And we anticipate that conversion at the end of March, which is what the organization, the current billing company has agreed to.
So that's on track, basically. It's tracking with what, when you first reported that to us back, I think it's in November, we're still, everything's moving still on that.
Yeah.
Okay. In home health, and maybe, yeah, you're on the right page there. So the loss for the month was $31,000, which is substantially less than what we've been seeing recently. It's about half of what we've been seeing. And why is that?
There was some catch-up billing from prior months.
Is that all that is?
Yeah, it's
Just-
timing issue.
It's just, we didn't have it booked before. Okay, so that's not an increase in census or anything like that. Okay.
No.
All right. And, hospice didn't see that. It was all in home health, right? That was kind of the question there. Let's see. Anybody stop me? So if we could go to page 30 then, and I don't know if this is Kim or you. But the census November, and then now in December, it's come down quite a bit. Could you just speak to that?
Mr. Chair, during,
Dave?
during that time, when was trying to think if there were, I know that they unfortunately had a few deaths. I think changed that. And then, of course,
So we were holding patients because we had a flu outbreak.
Yeah.
So it was roughly half the month, we stopped taking admissions. So we didn't want to bring new resident into an area that had active influenza.
Okay.
And so, which actually helped, I think we were down 6 or 7 patients by the end of the month.
Right.
And so when we had that pipe break, we shifted our patients in that broken pipe area into the, to allow us not to have to actually move people back to the hospital.
Is that resolved at this point? You're taking patients back in? Or
We're still down 6 rooms. But the pipe break, we're taking them, the influenza outbreak is over. But we were told we were having our rooms back on the 20th, but based on looking at the project today, I don't think that's gonna happen. So I'd get 2 more weeks.
Is there a lot of water damage over there or what? Were they frozen?
fire suppression.
It was a dry system, the whole edge of the pipe was burst out on the downward angle, so we think it was just a failure.
Okay.
But the beds that are available and that are open, have transfer admissions.
And then could you go to the next, to the hospice home care chart? And down just a little bit further, it's actually, yeah, that's the one I had questions about. So it looked like we were starting to make a little bit of traction around home health, but in the hospice, obviously, it's gonna go up or down, but you know, if I run a trend line across that hospice chart, it doesn't really look like we're making progress on that. Kim, I mean, what's your take on that?
That's through the chair. I think it's been challenging with home health and hospice. Fortunately, on hospice, you want your long length of stays, which.
Yeah.
Helps with that. So there had been, I think, 3 deaths in hospice, but still the referral patterns aren't there. We were having some challenges with staffing. So on the home health side, we did hold admissions for home health for 2 weeks. We had a couple of nurses unexpected to go out on FEMLA. That seems to be resolving. And so that area is back open for referrals, but we're still, still trying to do the education for hospice and getting folks in earlier than later.
What are the activities, if you wouldn't mind just kind of summarizing what you guys are doing around the outreach? Because, we heard that from Dr. Urata, and you have spoken to that about how important that kind of sustained outreach is.
So Heather Richter is still on. She's actually in town for the next.
Oh, yeah.
And so she's been helping do that. Nikki, who's the clinical manager at Home Health and Hospice, has been trying to do outreach, read flyers, pamphlets. We've been listing the help of Miranda, who's the volunteer coordinator and office person as well. A lot of it is just the education. They go to every kind of thing that they can in the community that's available to set up a table or talk about hospice and how it's important. I think honestly, just the challenges are some of the providers not quite maybe understanding that hospice isn't like, if you join now, you're not going to die tomorrow type of thing.
Yeah.
And so we do have several providers that have come on recently that are really interested in helping with that outreach. And I think that's going to be a game changer for us.
Oh, you do? You say the providers that have come on, are these the new employed positions or, oh, really? Oh, good.
One of them has a very strong interest in hospice and educating, and so I think that will be a good change.
So we're plugging away.
Away.
Anything further, Angela? Oh, Al,
Well,
sorry.
I don't want to name names or name organizations, but I'm sitting here as you're talking about this, I'm thinking of the institutions. So we now have family practice as part of our club. Family medicals, I think they're pretty strong in hospice. I mean, Bobby Otta was there, Ted Dunn's there, who's the medical director of hospice. Again, I don't want to name names. I'm just thinking, where are these institutions in this town that are elected, and how do we reach them? I mean, search is a big bunch of people that we haven't institutionally embraced, but
Sure, I
where
think
else
it's
could
a,
we?
it's a team sport, if you will, right? You also have, the family also has to be willing to enter into that agreement with hospice and be ready for that. And so I think there's some of that as well, especially as we see younger and younger folks with a terminal diagnosis. It's less likely that they're able to accept that and move forward. So it is, I would say, again, it's a team kind of conversation that has to happen with their provider and with the family being willing to go into hospice.
But I thought I was just hearing you say that there's a pool of providers in this town who aren't sympathetic to hospice care.
No,
I would get to those individual providers and make them more sympathetic, because every individual case is going to be an individual case.
I wouldn't say that they're not sympathetic. I just think hospice really for us is a new program. And so I think trying to it's still very new, even though we've had it for 2 years, trying to build it, it's still very new. And so I think we haven't had the opportunity to build those relationships because we've had so much turnover, like Heather leaving. She was a real champion at going out there. And again, I think with these providers that just came on board with Bartlett, I think that's going to be a game changer because they're going to be able to talk to their peers, but we haven't been able to really build that relationship with those providers on the hospice side to be able to maybe have them feel comfortable, of what hospice is about. So we are looking at that and every opportunity to educate too.
Yes, Doctor.
As a provider, I have never had someone come over to Valley Medical to say, hey, you should refer more. And I do step in the hospital, and so I do talk about hospice a lot. And I have definitely been very proactive about with my patients that I'm co-managing with Bartlett Medical Oncology, talking about getting them involved in home health, which I get some pushback because I get they're not homebound status. And I definitely get a lot of that, but we have a pretty debilitated senior or any person who has a life expectancy of 6 months to a year, which obviously I know can be renewed. And so it's not like a strong thing, but there's lots of people who qualify. And I have had people sort of tell me that they don't meet criteria to be on home health because the way to get people in is to have a conversation about their illness, get resources through home health when they are not at the stage that they're ready to be part of hospice. And part of that is that with Bartlett Medical Oncology being more separate, they are now, we used to see them all the time, Dr. Paddock, Dr. Dan, Dr. Malton, all of us at Valley Medical for their chemo care. And now that's been taken away through the nurse practitioners now being able to do that. So, a lot of people with advanced cancer that are just making some decisions about what they want to do. And so I have not had anyone come to Valley Medical, in a long time.
I can follow up with Heather Richter while she's in town and maybe you and I can connect with her, Dr. Hernandez, and we can go over the criteria and.
Yeah, and
see
I
what-
also definitely have not. I recently talked to one of the case managers because I did not know that Bartlett rehired its nutritionists. And so I have been referring them elsewhere because they were gone. And then I was like, so I would tell all my patients, Bartlett no longer has them, Bartlett no longer has them. And then apparently they do. And so I'm like, they did not tell us. I'm like, yeah, we're doing allocation, referrals and stuff. And I'm like, you guys are not telling me and you want me to send to people, right?
Yeah, I can send you that information. I was pretty sure that was presented at that staff that I can follow up.
But seeing my staff is different than sending a flyer to the office to say, hey, we now have these outpatient services available. I mean, you are using potential referrals because there's lots of telehealth services throughout the state of Alaska that are doing that. A lot of people who are struggling with their weight loss that have private insurance, private pay, who are interested in doing that.
I'm happy to get with Aaron and see if we can put another Facebook post out or see if we can do some sort of prep to send out to.
Yeah, and I definitely do not get my information from Facebook. Not extremely thing. I don't know.
Something to work on.
Can I ask a clarifying question? When were you notified that we weren't taking patients?
I was not, when was I notified that we weren't for nutrition?
Yeah.
I think when Cynthia Nickerson left, like, we also had Olga, I think at that time, and then they stopped, so they stopped diabetes outpatient treatment like several years ago. And I don't, like, I think I heard now that they are doing it again because case management just told me. Like literally 2 days ago, I was talking to Jeanette and she said something. I was like, I've been sending them to all these people.
Yeah, we never paused. What we did was we changed how we staffed it, and provided it. So we always continued with that program. So I think it was just, we work on the communication issue.
Yeah, I mean, I definitely did not know that. The nurses on the floor are like, they were like, we're doing diabetes education. So absolutely, for like several years. I know you guys get rid of cardiac rehab. That's a program that was really enjoyed by lots of people in the community. Through the chair, that program has been paused. It has not been canceled completely. And we actually have an A3 project looking at that because we're working with cardiology. Okay. Yeah, it's like a lot of those things were going.
So the other piece of this is not only is it, to your comment about notifying physicians, but patients who are dealing with a potential fatal injury, illness, often are not ready or in denial about their condition to the point where even if the physician were to allow a conversation around end of life care or hospice, patient absolutely refuses it. And that happened within my own family. So in September, and my brother-in-law should have been in hospice 6 months before he died. And instead, he got on hospice a week before his death. And I will just tell you, it was a horrendous experience for our family because he actually thought he was not dying. And it was absolutely stunning that he and his wife believed that he was not dying. Yeah.
So I totally get that. And I feel that it's my role to be able to say, let's do home health.
Yeah.
And I absolutely have had that conversation for 23 years because I do think that getting them on home health with a transition to hospice when they're ready. And part of that is that if someone's actively going through, even if it's palliative chemotherapy, that would exclude them from hospice, but it would not exclude them necessarily from home health. And I do think that it's important. And hospice is great and we are very pro hospice. Taylor Dunn is the director, Bob Grotto was the previous director. We are very pro hospice. And I do feel it is my job to, prepare not only the patient, but the family for that. And so, I want to support you guys. And when Angela sort of said we should get them in sooner, I'm like, okay, I've been getting a lot of pushback. I did not know that, that was the case.
Yeah.
But I also, in defense of Bartlett, Search has a lot of resources and I have no idea what they're doing and I never know when they're around either. So apparently just communication.
I think this has been a really good discussion that needs further follow-up. And it sounds like Kim is going to get some information back to us, but I'd like to see us get back. This is really a finance committee meeting.
Okay, let's move on to the senior team performance compensation. I think we're done with the financial piece, right? So do you want to kick this off, Joe, or do you want me to?
I was gonna let you.
Okay, so at our retreat, we, one of the discussion areas that we kind of stumbled into was compensation, how compensation tied back to the board's strategic goals. And we found that there really wasn't as it related to compensation, that we don't have a performance-based compensation metric that's part of your compensation or any of the senior teams, right? And my recollection of that conversation was that we wanted to gather information around what's best practices for, what other hospitals in the state are doing and what, kind of industry norms are around performance-based compensation. So I asked to include this so that I guess we could have kind of for lack of a better term, kind of a meeting of the minds of the board to move forward with that, you know, kind of that process. So, the way I kind of envision is Joe, you know, working with, I can never remember because I'm so used to saying AHA forever.
It is AHA.
Oh, it's AHA. Oh, it's that's right. I knew it changed. So get with AHA, you know, potentially talk to B.E. Smith, come back with some comparables, and then have the committee kind of evaluate those and come up with, you know, potentially a proposal and take to the full board. It's kind of what my thought was.
I support the idea of getting more information. I'm a little skeptical of a lot of performance compensation, that it's very squishy and it ends up just being a paperwork tracking task rather than actually changing performance.
Yeah.
But I would be interested to see how it's being handled at other facilities and if people come up with a good way.
We have to feel like it's going to be an effective.
Right.
tool,
Yeah.
Right.
Exactly. That's,
Yeah.
I would only want to do,
I think
I want to make sure something's effective as opposed to achieving your strategic goals, which some of them may never be achieved. You will continue to work towards them. So at the end of the year to say we did a good job working towards them, it could be very arbitrary.
I'll just say that in principle, I'm very much in favor of this, and it is arbitrary, but arbitrary comes from the same root word as arbitrator, which means it's a judgment. It is a judgment, but, and it should be a judgment. But when I've seen this done poorly, where it's just kind of a bunch of paperwork and then the money's handed over, that's the result of poor performance by the board. So I think for this to work, this has to be well crafted by the board. We have to be very clear about what we want, and we have to be very clear about what the steps are. So I think that's on us, but I would say for me, I'm in favor of this.
Yeah, you know, my own personal experience around developing these programs and watching them kind of mature is that they require for success a tremendous amount of specificity. You know, you've got to be very detailed about, you know, identifying what the goal is and what the metrics are to measure the goal and what the steps are towards that goal that result in percent of bonuses and that kind of thing. Normally, there's several different metrics that are used with different measurements. And I completely agree with both y'all's comments that if this goes forward, it has to be done in a way that is very measurable and, you know, with goals that we all, you know, agree are worth pursuing. So, so next finance committee meeting, Joe, you can come back with some information for us that, you know, in terms of, be interesting to know what other hospitals are doing, you know, what, you know, AHA has to say, what B. Smith potentially, since they've been involved in that for us.
Well, we can look at these, that we use ECG for physician compensation.
Okay,
This board actually did some kind of study back when Chuck left too. Just review minutes and dig that up and see what we used it.
Yeah.
It's been looked at in the past, and just with the action.
yeah, at least,
To me, it would also be helpful to know how the current compensation fits with compensation for life patients and so alongside hospitals too.
Next month.
great, thank you. Housing update, we talked about that a little bit earlier. If you could just give us kind of an update on the conversations you've had with Jensen and.
Well, we have the surveyors came in during the month. Snow was an issue with getting the survey completed. There's still 2 monuments they weren't able to find to coordinate is the building where it needs to be to make the renovations work. There were some issues with prior surveys where we weren't lining up exactly, so they don't know if monuments were moved at some point. So that's why they need to find those last 2 before we can coordinate, make sure we have the space to build it. We were reaching out this morning, trying to get an estimate It's a couple weeks away from that. And that's why we had that placeholder and we put it in the budget. Which was our kind of early conversation estimates with Wayne when we first kicked this off. And so, but now that it's a BRH project, you can assume it's gonna be much more expensive because we're going to process it. With the thought process, we will go after rural health transformation funds. We're also looking at CDS funds for doing Murkowski one last time. Real estate time, so, and let's share those, I guess.
Yeah. So the scoping for this will precede, going after, I mean, we have to first have a project, right?
Yeah.
But we can't really proceed at this point now until we've got an appropriation from the CBJ. Is that accurate?
I can't actually action anything until you have an appropriations, yes.
Yeah. I mean, it just changed, the nature of the change when we found out who the owner for it. All right. Okay, well, that's fair enough. I mean, we've got to follow that process. But again, I want to cover this next week when we meet with them.
So in the short term, though, we did acquire an additional rental property that became available to us.
Okay.
And we got onto that, and so we have. Would you say adequate amount of short-term rentals, yes? Closing in on
We're
adequate.
closing in on, yeah. Yeah, ideally, I wouldn't mind another 2-bedroom. Or 3-bedroom.
How do you have much yet?
I believe we have 7. Combinations of 2 bedrooms, 3 bedrooms.
They're all-
The challenge is for on the recruitment retention side, sorry, the chair, is that we don't control, we don't get to control things like whether or not they allow dogs. So in certain cases, or, we've had people who want to come up and live there permanently, they have pets.
Yeah.
And, that becomes beyond our control. Whether or not we can use that because we are renting from other owners.
Yeah. I mean, it's a stopgap measure, right? That's the intention for sure. Anything more on housing update? Committee comments and questions? Like a really long finance committee meeting and almost an hour and a half. For heaven's sake.
But we're in our 10 minutes, I think, or we said.
Oh, that's right. We didn't start until a quarter after,
Yeah.
did we? So
You
we're
were
just
just here.
Okay, I'm feeling better about myself.
I guess, thanks for all the work that you put in, and you and your staff put in on the cleanup, over the last year, working with the auditors and, getting this budget out a little bit earlier than we have in the past. So, thank you very much.
Certainly faster than that guy we had last year.
That's
2 years.
That's
ago.
Yeah, damn, I missed my chance.
Any other comments or questions?
Here.
Yeah, yeah. I was slamming Joe and I missed my one.
This year.
All right, 6:23, we're adjourned. Thank you. You?
No, it's something we need
This from creative state. I should.